Well, I'm just gonna go real quick because so we have some time for discussion after, and go directly to the answer. So, is there room for augmentation cystoplasty? Yeah, it remains an option in both type of patients. Obviously, the neurogenic patients, but also in the non-neurogenic patient. And the main idea is that you have to go there to augmentation cystoplasty when conservative treatment, pharmacological methods, and all minimal invasive treatments have failed or have exhausted. So now the aim of the technique is to provide a good urinary storage, to protect the upper urinary tract, preserve renal function, provide continence to patients, resistance to infection, and offer, obviously, something convenient for the patient. And its indication mostly lies in the fact that when you have a bladder with small capacity, which has become defunctionalized, you need to go to augmentation cystoplasty. So, yeah, the indication is still here today. We'll see then in the end that how many do we have to do, and that is maybe the best questions. So it was first described in 1988 in the animal model, and then 1 year later in the human by von Mikulitz. Actually, the technique started to be a little bit more popular in the 1950s by Kuvler, and what really changed the approach to that technique was the introduction of self-catheterization. There are different techniques available in the literature, and different techniques are described, but the most frequently used one is with the use of helium. It's the most frequently used bowel segment, ideally 25 to 40 centimeters of bowel. From the ileocecal valve. It is detubularized in various shapes and usually attached to the native bladder, which has been a little bit reduced. Other techniques have used sigma, which also is detubularized as a straight patch or a cup patch. It's the most common alternative to helium. The advantages are that it has a thick muscular wall, large lumens, and therefore it allows a great bladder capacity. But the disadvantages are the higher risk of UTIs, a larger production of mucus, and theoretically a higher risk of malignancy. But we'll see that after in the complications. CCAM can also be used. It has great mobility. You can do good anastomosis with the ureter. However, you may have malabsorption problems associated with the resection of the ileocecal valve. In the literature, I have actually no experience with that technique. Maybe some of you have in the room the gastrocystoplasty. Whenever bowel is unavailable, you can try to use the stomach, and you will have less issues with mucus, with infections, and the metabolic syndrome. But obviously, it can have some consequences. And still today, the best way is to use the helium, and that's what's proposed. For complications, they can be classified in early complications, which are more or less the one that you find in all surgeries: wound infection, small bowel obstruction, bleeding. It is important to point out that regular self-attempted catheterization is needed in 6 to 40% of patients, and it is important to point out that mortality rate is not low in these procedures, as it can reach 7% in the literature. So it's not something that you can forget. Other complications where they are varied, thromboembolism or cardiovascular complications which follow the procedure, but we'll focus more or less on the most infrequent one, which are infections, stone formation, bladder perforation, reflux, metabolic disturbance, urinary and bowel functions. I really like to emphasize the fact that stone formation is something that is really common in these cystoplasties, reaching almost 40% in some studies. Usually it is 5 times as common in augmented patients who need to perform self-catheterizations. So more or less it doesn't appear in patients who void spontaneously without post-void residue, but it can happen in patients, however, who will have who do not empty well their new bladder. Stasis is the important factor in stone formation. Usually they are triple phosphate stones. It implies that there may be a cause linked to bacteria presence. Obviously, there are other risk factors, especially staples, because I think there's many teams use automatic staplers, which not only neurologic patients but also in regular urological patients can be a problem with a stone formation. Obviously, mucus is a problem. Other risks, carcinoma. It is thought that there's a risk of bladder cancer higher in patients with congenital bladder dysfunction. There's a controversy as to whether enterocystoplasty is an independent risk factor for carcinogenesis. Actually, in the literature, the approximate risk is of 1.2%. It seemed that the carcinoma were more or less associated with tuberculosis or other risk factors and tobacco use. It is important to state that usually it is an adenocarcinoma and not a urothelial carcinoma, and there is a long latency period between augmentation and the occurrence, which mainly 20 years. Those are the risk factors for carcinoma, urinary stasis, infections, the stones, which is always a recurrent point, immunosuppression, chronic patch inflammation. As I said before, the tumors are usually located, the tumors are generally adenocarcinomas, but mostly they're located in the region of the anastomosis. Other problems with these patients is incontinence, and especially nocturnal enuresis, which can be attributed to reduction in continence measures, so in urethral closing pressure. But usually it can be due or to an overactive bladder of the residue of the bladder which is present, or otherwise as a failure of the sphincter to increase its pressure in response to the contractions from the bowel patch during sleep. However, this can be managed by anticholinergics, of course, self-intermittent catheterization, but sometimes bladder surgery or other continence surgery. In the literature, it seems that the surgical correction usually required only for selected patients with either congenital sphincter deficiency or neuropathy. But today, the most frequent outlet procedures, which offers the maximum chance of spontaneous voiding, is the artificial urinary sphincter, which can be closed or opened. Some teams propose to perform it concomitantly with the augmentation cystoplasty. However, obviously, it is difficult to know if your patients will be incontinent after HEFIS, not before. So for the answer, is augmentation cystoplasty present? We said already yes, but it is important to show in this interesting graphic that since we had other techniques, such as Botox and antimuscarinics, the trend is definitely going down. So I think that's more or less the important slide of this presentation. And in conclusion, there remains a role for augmentation cystoplasty in the 21st century, but obviously there's greater competition from less invasive procedure. But as we talked a little bit about it before, mostly it's the compliance of the patients to other techniques which will lead you to augmentation cystoplasty. And I was just finished with that, saying that we have good results. Usually, I think Professor D'Ancona has much more experience than me on these procedures for obvious reasons. And that's it. We'll just go, I think, with the questions.
Thank you, Julien. We have time for questions.
Thank you very much for both your presentations. First of all, at a personal level, I'd like to thank you particularly for putting up a picture of Giles Brindley in 1982. I was working with Giles in 1982, an extraordinary man. The second was a question about the timing of repetition with repeat injections with botulinum toxin, because when we go through a wear-off period, at least in the UK, there are many patients who end up untreated for a period of time, and that seems to undermine the whole point of having botulinum toxin treatment. So I don't know if anybody's managed to find a way of timing the treatment without running into problems of antibody production, so that patients, particularly the MS patients that I deal with, don't get problems with return of symptoms. The third is a comment, if I may, just to let you know that there is now going to be a resurgence of the use of intravesical therapeutics for the purpose of dealing with neurogenic detrusor overactivity. I think in the first talk, in the first slide, there was a comment that the pharmaceutical industry was not interested in that approach. But over the last 20 years, there's been a real development in our understanding, or certainly identification and understanding, of urothelial receptors, and also an emergence that the use of systemic treatments are really too problematic, poor compliance, and a whole range of effects. I think the lesson that botulinum toxin treated was the question, what is the lesson? And I think the lesson is one that we should all have known all along, and that is if we get directly to the site of action without going through the system, we get better overall holistic results, if I may. But the idea that intravesical therapeutics will be coming on stream is based on new technology about delivery. That means that patients should not run into extra infection problems associated with it.
You are saying the truth. For example, we had the possibility to have a galenic oxybutynin to put in the bladder that is working very well with good results. But what is the problem? The problem is that the price of a pill of oxybutynin, that is the only one approved for our patients in Italy, is that higher. And it is difficult to use this. We can use only when patients are inside the spinal unit, but for outside the spinal unit we cannot use.
The problem with oxybutynin anyway is that it's very lipophilic and crosses the blood-brain barrier rather readily. And there was a paper just produced a few months ago in JAMA Neurology about the effects of antimuscarinics on brain, and it showed that it produces both brain atrophy and confusion, as well. So there's a whole issue around oral treatments anyway. But the beauty of the urothelium is that it provides a very effective barrier to both systemic absorption and certainly crossing the blood-brain barrier. And with MS patients particularly, the thing that is never mentioned about the side effects is that it affects sweating. And these are people with severe sensitivity to changes in core temperature.
Yes.
Now the point is the intravesical use of a quaternary ammonium compound, and I know that atropine will be coming onto the market for this purpose, is that the urothelial barrier will present the effects, and of course we now know that it is the sensory arc that we can block, and it should address all of these neurogenic cases.
Yes, but in '99 we have an experience after the use, preliminary use of capsaicin in the use of resinifera toxin. Resinifera toxin is working well. But no companies were interested because it's not a business and the category of spinal cord patients.
And I think also there were some, I think there's one article that you recently used liposomes containing Botox, which with a long release after installation in the bladder. But
the essential limit to intravesical therapy, which has a wealth of opportunity, was the delivery itself increasing the risk of infection. Because you're dealing with symptoms as opposed to life-threatening issues like cancer and so on and so forth. The idea of using intermittent catheterization and sending drugs through the brain and is unacceptable. That problem has been resolved. and I know that within a year it should be launched within Europe.
But that will be interesting mostly for the category of multiple sclerosis patients. It is true that I think for spinal cord injury patients, that's less an issue because anyhow they have to self-catheterize. I totally agree with you, and also with the problem with Parkinson patients, because we talk a lot about multiple sclerosis patients, but Parkinson's patients, they're even more neglected sometimes because they don't have the problem with the detrusor sphincter synergia, so nobody really focuses on them. Mm-hmm.
By bringing it back, and this will be a self-management, so we will take it out of hospital. It's a very big issue in the UK.
And to answer your first question, which was the one that of the timing of Botox, actually it's quite difficult because it's a paradox that you have to. I know, for instance, now in Notville, what they do is when they do the Botox injections, they do a urodynamic 6 weeks after to see if the effects. But the problem is that you won't know if it's going to last a year, it's going to last 3 months. Obviously, you have to wait for patients to lose urine. That's usually what we do. The patient comes and says, "Oh well, I started losing my urine. I think the Botox didn't work." But the problem is that you lose the timing because maybe the patient has lost the effect of Botox before.
And I pick these patients up all the time because between the urology appointments, they're coming to see me, running into trouble. And so I'm very aware of this as a particular issue. I'm hoping that something will actually resolve the problem, but I don't know.
No, I think because it's linked tightly to the medical system of the country. That's what I think. I mean, I had the chance. Yeah, no, but I know. But I mean, I had to work. I had the chance to work in Michele. I have the chance to work in Switzerland, and in Switzerland, I worked in different clinics. The Geneva University Hospital, which is a general urology clinic, where I'm the responsible for the neurourology thing. The problem is that if you need to have an appointment, it's pretty tough. So if I'm not here, patients usually have my email and they tell me, okay, I have a problem, and I see them quite fast. It's the same, I think, in Notville. But the problem, for instance, for Michele, which drains almost 60% of Italian neurological patients, I'm not saying that because he's here, but he sees all the patients possible in a day. But that's why it's highly linked to the medical system, because the patients need to see their physician, and the problem is they don't have access to it because we're few physicians focusing on it, at least in Switzerland, and yeah, it's a problem.
I'm sorry, but we have to close. We have to close. And Carlos, do you want to have a final comment? No. No. Thank you to all. Let's hope to go on with this interest argument and have a good lunch.